Biology fellows here. So our purpose, just to review, is to create a forum in which members of a multidisciplinary healthcare team can engage in objective, non-judgmental review of adverse outcomes and commit to systemic process change. Our guiding principles are to foster a safe, open, respectful environment that facilitates discussion, learning, and teamwork, and to focus on systems factors as root causes of adverse events rather than individuals. We want to look for underlying systems-level causations that were manifest in personnel-related performance issues. And everything that we discuss is confidential and privileged pursuant to the Tennessee Patient Safety and Quality Improvement Act. All right, so to review briefly our action items from the last case. So from radiology, I did speak to Dr. Calvert, and he did confirm that new hematomas specifically related to pelvic fractures will be orange or red, depending on the size, so the provider will be notified for those. And we have a couple of items that are still in progress that we discussed last time. Parameters for reporting abnormal vitals by nursing. I know that Ted Nelson is working on this. And then we'd like to see a warning for increased INR or abnormal coags when ordering anticoagulants. They're still working on that one. All right, so today's patient safety conference is going to be a little bit different because rather than focusing on one adverse event in one case, we're going to talk about our treatment of sepsis in general as a health system. So the problem of sepsis. Well, sepsis is the leading cause of death in U.S. hospitals. It's responsible for 1 in every 2 to 3 deaths. And patients with initially less severe sepsis make up the majority of hospital deaths. The literature tells us as many as 80% of septic shock deaths could be prevented with rapid diagnosis and treatment. And poor recognition and treatment of sepsis is felt to be the biggest threat to patient safety at Erlanger and our adult hospitals. So this is data from the Tennessee Hospital Association. This is for overall sepsis mortality for adults. So we are in blue, the state of Tennessee is in green, and then national data is in orange. And you can see the rate of overall sepsis mortality for adults. For state and national, it's running about 100 cases per, Natalie, is this per 100,000? It's per 1,000. Okay, so 10%. All right. So that's where the state and national data is. We're at 150 cases per 1,000, so we're 1.5 times higher. And then for hospital onset sepsis, it's even worse. Once again, we're in blue, and we're significantly higher than the state in green and national data in orange. We're up around 500 cases per 1,000. You can see the others are at 200 and 300. So what can we do to improve sepsis mortality? Well, I think we can do several things that we're going to touch on today. One, we need to improve our recognition of sepsis. So I'm involved with a group that is working to refine the sepsis BPA so that it is less of a burden, so that it's more specific and is actually helpful in identifying these patients. Additionally, we're going to talk a little bit about use of sepsis 2 definitions for sepsis at Erlanger rather than sepsis 3. Next, we can improve treatment of sepsis, and we can do this through bundle compliance, and we're going to talk about the evidence for bundles today, and we can make sure we're meeting all of our bundle requirements through using the sepsis order set. And then we can improve our documentation so that we're getting credit for the care that we deliver. So just briefly, sepsis 2 versus sepsis 3. You can see that the sepsis 2 definitions are actually the current CMS definitions for sepsis and are used with the sepsis bundle. They're also the ICD-10 definitions. So you guys are probably all familiar. I won't go through this in detail, but in general, sepsis 3 defines sepsis as life-threatening organ dysfunction, and so it removed the 3 levels of sepsis and just made it into 2 levels. And that's where we got Q-SOFA and the SOFA score. And just as a reminder, this is the full SOFA score that you can calculate and all of the different components. So there are increasing questions regarding sepsis 3. These are just some concerns I took out of or disclaimers I took out of the actual paper from the Sepsis 3 work group. But there's not been any prospective validation of this, and there are increasing concerns about using it as a screening test. I've really got a whole presentation about issues with Sepsis 3, but I'm going to only focus on two things for the sake of time today. So the first is a sensitivity problem with Sepsis 3. So SOFA and QSOFA were designed to predict mortality and ICU stay greater than 3 days, not to screen for sepsis outside of the ICU. QSOFA and SEERS perform similarly in mortality prediction, and you can see that by the ROC curve, but QSOFA trades sensitivity for specificity. So one of the issues with that is that the Sepsis 3 authors indicate that QSOFA, which we all kind of view as a screening tool, that it should actually be followed by the SOFA score. And this doesn't really make sense, as QSOFA is less sensitive and more specific than the actual SOFA score. And so if you look at the algorithm from the paper, they actually have you follow up QSOFA with a SOFA score. And then SOFA is difficult to calculate outside of the ICU and outside of academic centers. And this has created confusion that's led to decreased recognition and documentation of sepsis by hospitalists nationally, and it's definitely a problem at Erlanger. And those are the folks who care for the majority of septic patients. So for those reasons, at Erlanger, our administration has decided that we should use Sepsis 2 for our documentation, our diagnosis and recognition of sepsis, and we're going to talk more about how that comes into play with the bundle. All right, I'll hand it over to our QI team.
So here we will start with a case. This is a 66-year-old female who comes in. She has a history of recent bladder floor reconstruction with repair of a rectus seal. She has a bladder sling and a stimulator that were placed 6 weeks prior to presentation. And she comes in presenting with fever, nausea, vomiting, and abdominal pain. And so she arrives to the ED at 14:21. These are her triage vitals. So originally she's afebrile, she's tachycardic, normotensive, and mildly tachypnic. At 14:35, we have some of the labs back, and the white blood cell count is 15.7, and so blood cultures are drawn. Almost 30 minutes after that, she gets a lactate done, which is 7.3. The ED puts in their note that the patient has an infection. They presume it's diverticulitis. At 16:32, antibiotics are ordered, so she gets Levaquin and Flagyl. And then she gets paged out to an admission to hospitalist at 16:45. Eventually at 18:10, there's a repeat lactate that's ordered, and this is not drawn until almost 5 or 6 hours after, which is now the next day.
All right, so in talking about this first case, we need to kind of define and talk about what actually the CMS Sepsis Bundles are. So the Surviving Sepsis campaign developed these bundles in 2005, and they update them periodically when new evidence is available. We're going to talk about one of the more recent updates in 2015. And it's showing that there's compelling evidence in the literature for an association between compliance with the bundles and increased survival in sepsis and severe sepsis, along with septic shock, which is what we want. So these bundle measures were adopted also by the National Quality Forum and also by CMS, which affects all of us because we need to comply with that, obviously. And also an important note is that bundle performance is now publicly reported. So the compliance that Erlanger has with the bundles, you can go online and actually look and see, along with our rates of sepsis and death from that. So the 2015 update looking at compliance and outcomes, based on the original 2004-2005 guidelines, study was from January 1st, 2005 to June 30th, 2012, involved 29,000 patients. 218 centers were involved in the US, Europe, and South America. They took patients from the ED, ICU, med-surg wards who met diagnostic criteria for severe sepsis and/or septic shock. And the compliance with the bundles was defined as that all the bundle elements were achieved. You could have one or two, but if not all bundle elements were achieved, that was deemed as not full compliance. The results showed that overall there was lower mortality in the high compliance group, 29%, versus the low compliance group, which was at 38%. And that was the resuscitation bundle compliance. And also that hospital mortality rates dropped by 0.7% per site for every 3 months that site participated. Overall, the analysis demonstrated that there's a 25% relative risk reduction in mortality rates with increasing compliance of the bundles at each center. And just to talk general about these, they are performance metrics. They can drive change in clinical behavior and may decrease mortality in patients with severe sepsis and septic shock. That's what makes them so important to us.
So here at Erlanger, this is our rate for compliance from August of this year, which is 33%. More recently, it's now 39%, and this is the national average, which is 51%. This is everywhere. And so even the national average for compliance with these bundles is quite low. And so there's definitely stuff that we need to be doing to improve these numbers. In terms of what is compliance, and so this is based on which category of sepsis the patient is classified in when they first come in. And so if it's just sepsis, which is defined as 2 SIRS criteria and a suspected infection, then there's no actual bundle that you're having to keep in line with. And so for 3 hours, you just need regular cultures and antibiotics, and then there's nothing that we're looking at for the 6-hour mark for these patients. For severe sepsis, which is the same as sepsis but with some organ dysfunction, which includes initial hypotension when they're first triaged, a lactate greater than 2 if they have any altered mental status, respiratory failure, kidney injury, or liver injury, or coagulopathy. And this is when you have to have the bundles performed by 3 and 6 hours. And so at 3 hours, you need blood cultures, antibiotics after blood cultures. You need an initial lactate level, and then you need your fluid bolus for an initial hypotension or lactate that's more than 4. And then within 6 hours after this, there needs to be a repeat of that lactate to ensure that it's downtrending. For septic shock, which is here defined as tissue hypoperfusion, meaning either a systolic blood pressure less than 90, a MAP less than 65, or a decrease in the systolic blood pressure of 40 points or more, or a lactate that's greater than 4 initially, would put you in this category. And in this case, the one extra thing that you would need on top of the severe sepsis would be adding vasopressors if there's hypotension after the fluid bolus. For this one, after 6 hours, you still need the repeat lactate, and then the new things that you would need to do is you would have to have started the vasopressors. If you're not going to start vasopressors, then there needs to be a documentation for why those weren't started. And so you need a repeat physical exam to show that they have improved vitals, and then you also need to show that the volume status and tissue perfusion has improved. And so there are certain things you can do for those and document in your physical exam as to why you're not using vasopressors at that point. And so looking back at our first case, this person did meet criteria for what would be here severe sepsis. Actually septic shock because their lactate is more than 4. And so for this person, they were tachycardic, they were tachypnic, they had a leukocytosis, a lactate was 7.3, and they had a possible infection that we know of. And so if you look at the bundle criteria that were met, so there were blood cultures that were ordered prior to antibiotics. They did start broad spectrum antibiotics. They had an initial lactate level, which was elevated. This person was not given their fluids for their lactate of greater than 4. And this person did not have a repeat lactate either that was within 6 hours. And so for this case, we failed in this, basically in the sepsis bundle because of these 2 points. We have another case.
So this case will discuss a common theme that we encounter in the hospital here, and this is in regards to fluid resuscitation. So in this particular case, we had an 81-year-old female with a reduced ejection fraction of 25%, history of recent PPM, presenting with chest pain. Her initial vitals, afebrile, normotensive, non-tachycardic, respiratory rate of 22, so slightly tachypnic. Her initial labs showed a white count of 15, lactic acid of 1.34, T-Billy of 2.3 with some transaminitis as well. Overall, her electrolytes were normal. 8:34, there was a concern for pneumonia. The admitting team was paged. Community-acquired pneumonia was diagnosed, and antibiotics and blood cultures were ordered for the patient. At approximately 11:30, her blood pressure fell to 79/52 and remains low on recheck. At 12:35, ED providers order 1,500 cc's of normal saline despite weight-based indication for 3 liters in this particular patient, going along with the 30 cc's per kilo per the sepsis bundle. Provider noting that CHF precludes that amount of fluid being too much, the 3 liters that is. So a lot in the emergency medicine literature and the critical care literature of late has been looking at this, and multiple studies compared 2 groups of septic patients with either documented heart failure or ESRD or other patients with who were prone to fluid overload, and compared these patients of those who were receiving at least 30 cc per kg bolus or those who did not in the emergency department. And the findings that they had there, the concern is that they become volume overloaded, and this affects their respiratory system. However, there were no differences in intubation and then no difference in hospital length of stay or mortality. However, some of the studies were not powered to actually look at mortality, so that could be the slight against them. In heart failure and or ESRD patients who do become septic and receive at least the 30 cc per kg bolus of IV fluid resuscitation, which was 13.8% of the CON study there, are not any more likely to be intubated than those who received a fluid restrictive regimen. Other studies have gone on to show that CHF patients who are hypotensive and have not received adequate fluid resuscitation actually had higher mortality than those who had not. However, that was not statistically significant. Other retrospective studies have also showed, kind of going back to the form point, under resuscitation of those hypotensive patients with sepsis and CHF leads to higher mortality and higher intubation rate, which is the exact opposite thought that usually precludes us from giving these patients and giving them all of those fluids. There was more data demonstrating actually a comparison between those with pre-existing left ventricular dysfunction versus patient with a normal ejection fraction during sepsis and were treated according to the guidelines, and noted there was no statistical significance difference in clinical outcomes between both the normal EF and the reduced EF in hospital mortality or in intubation in 24 hours. At the end of the day, in regards to fluid resuscitation, this should be guided by our fluid responsiveness of the patient as well, so maybe even beyond 30 cc per kilo bolus. So revisiting this case, this patient hits a lot of the high points in terms of sepsis as previously shown in our bundle: tachypnic, white count, end organ dysfunction. She meets severe sepsis criteria. However, we did fail to give her the initial bolus of 30 cc's per kilo that the patient needed. Blood cultures were drawn, which was appropriate, as well as broad spectrum antibiotics and an initial lactate. And our colleague here is going to discuss the rest of this case here.
Cool. So for both of these cases, where do you guys think they fall along these wheels? Like, did the patient die from it, or nothing happened, or somewhere in between? Or do you think these patients may have been hospitalized a little bit longer than they needed to, or they needed to have a little bit more intervention? ERF, basically. Bottom line, kind of like in the EF category, so they kind of had temporary harm, may have been hospitalized for a little bit longer than they had to, so probably in the EF category. So the next thing we're going to do is kind of split off into groups of 4. There should be handouts available for you guys to do a fishbone diagram, and kind of just identifying system level errors and then sub-causes for that to figure out what exactly was going on. So here again are those lists of system factors for you guys to review and just kind of think about.
And we want to think in general about why we're having difficulty meeting the sepsis bundle requirement. So you can use these cases as examples, or you can think to your prior experience. So it's not based on just one patient, but just in general, why are we having difficulty meeting these 6-hour bundles?
We'll give you guys 10 minutes to talk and discuss. We'll give you guys 10 minutes. All right. You guys got stuff? All right, so go ahead and raise a hand or elect a representative for each of your groups. All right, representative. I only see 2 hands out of what should be more groups. All right, 3 hands.
All right, who's ready to share?
I think for one of the categories, EMR, and I think alarm fatigue is a big problem for a lot of us.
So you say that's a system error, system factor? Cool.
Sure.
All right.
So does that relate to the sepsis BPA? Like it's just getting ignored? Yes. Yep, not helpful in that way. Okay, all right, next.
One of our big ones was training education. We didn't, for example, the repeat lactate at 6 hours, we're still not sure, does the result have to be in within 6 hours, or that lab has to be drawn within 6 hours?
Completed.
Okay. Okay, reported. Okay.
And I think one thing to remember, we tried to illustrate this on the cases, is that the presentation time for severe sepsis or septic shock is not until all of the criteria were met. So it's not like the triage time in the ED is our start time. It's after we've gotten that initial testing back and we have labs and a diagnosis of infection. So we can do this. You know, we just have to be diligent about it.
I think to add on that, we were talking about like education and things like that, on like education about, like, I think this is very helpful to have like the card to make sure like we're meeting these criteria. But another thing is, even if these things are ordered, it's not always done in a timely fashion, and it may be, you know, in the ICU usually they don't have as many patients. They're able to, you know, if we want it done at 2 o'clock, it usually gets done. But if they're still down in the emergency department, they're slammed down there, and to get this repeat drawn, it's a little more difficult. And then we try and follow it up, but it just doesn't always work out.
Absolutely. So we could put that under a lot of different headings, but just, you know, time and making sure that these things are done. Absolutely. Do you guys want to share?
Sure. Just pick one or two, or? So one of the big ones we had was the local environment. Like, we don't have appropriate hemodynamic monitors or a good cooling system still. And I feel like those are 2 really important things for us to appropriately treat our sepsis patients.
Okay. Awesome. All right. Yes.
This may have been addressed already, but one of the things that we specifically noted a knowledge deficit for teaching regarding sepsis in the setting of CHF, and are there protocols specifically in place for sepsis in the setting of CHF, and benchmarks you can use to guide fluid resuscitation in the setting of CHF. Also, institutional factors, and this was just addressed, but more just to say it specifically, at times it appears, at least subjectively, as if there is inadequate staffing in the ER for the nurses to draw the labs appropriately, the staff to draw what is ordered, and then orders seem to be filled in a haphazard fashion. Those were 2 things.
Okay. Thank you. All right.
So you guys would call that under a local environment issue or something else? So you'd say institutional factors and uncertainty as to how the protocol works, or?
That was training and education.
Under here?
I think it's training and education about what to do with the CHF patients.
Okay. Oh, okay.
And then it was local environment or institutional factors on staffing adequacy, specifically in the emergency department.
No, I do have a question. If Do you think, like, if we treated code sepsis like we do a STEMI or stroke and have those resources, do you think it would make an impact? Making sure everything was filled? Because, I mean, that's what it's a medical emergency in most institutions. That's how they're meeting some of these compliance measures. And it gives you extra resources, like you have the stroke nurses. I mean, it's like sepsis nurses. Would that be beneficial to, as far as making sure things are completed and even documentation completed? It could be on an APN level. I mean, it could be an extender.
For sure, and I think we can come back to that. We're going to create some action items. Right, exactly. Sorry, I took the mic.
It's okay. So this can lie under local environment. The first lactate was ordered at 6:10, and that's usually when handover happens in the ED between nurses. So I guess better handover between nurses, or because situations there happen when they're in the middle of handover and something happens. So I'm not really sure what the best approach would be to fix that, but that could be likely causing the reason why the lactate wasn't drawn at that time.
All right, any other categories to add that we haven't done yet? Yes, Tom.
EMR/CPOE, alarm fatigue for the sepsis alarms is a potential problem.
Anything else?
Kind of echoing off the EMR and the reason the lactate wasn't drawn. I know just from personal experience in the ED, a lot of times they will print off all their labs that are due for 4 or 6 hours, and you actually have to hit collect in Epic to make that happen. And a lot of times they'll get up to us, and then a few minutes later we'll have this massive amount of labs tubed to us. So I think something that would possibly stop that would be just having them not print them all off down there, because we can always see in the ICU what has been ordered in the ED.
So maybe that it might even be task factor. Like you can make a new category. We could probably put that under several things, but just the way that the process is done for drawing labs in the ED.
So under training education, we would say all of the cardiology fellows in the room have all been talking about this. We actually get called about this quite a bit, about sepsis in the setting of CHF. And our response to you would be that if you think the patient's in septic shock, you give fluids. That's the treatment. Doesn't matter what their EF is. If you give them too much fluid, in the end, we can always take it off, but you have to adequately resuscitate. That's treatment for sepsis. So that's what we would, if you call us, that's all of our answer.
Thanks so much, Kelly. I will say that 2 weeks ago, I had a patient with an EF of 10%. Was anybody on my team then? Are they here? We gave them like 3,900 mLs of fluid and no volume overload at all. And it was just such a reminder that even in the worst case, the guy had septic shock and did well after that. All right, anyone else? Okay, let me send it back to you, Shanting.
Sounds good. So basically here under the EMR section, we've got concerns about alarm fatigue, like the sepsis thing constantly popping in your face. Some things noted by a couple of people are issues with labels being printed off too early or not being able to figure out what the status of the labs are. Under training and education, most of that is like trying to make sure that the lactate gets redrawn or figured out and appropriately ordered. Other one was CHF, like making sure that they get treated appropriately with sepsis and the fluids. Local environment issue, monitoring, telemetry, blood pressures, staffing, maybe possibly having a dedicated sepsis nurse, making sure there's appropriate handoff for septic patients to actually get the labs drawn appropriately, and fluids delivered, and then some institutional factors kind of glanced over, but tasking issues like kind of reiterating the EMR situation, and then also possibly some issues that maybe that's more not a task issue, but institutional factor, the fact that the lab does not have Epic to actually see your lab status, possibly. All right, anything else? Any other thoughts, ideas? Cool. So, kind of went on those. Got those action plans section here. So, Do you want to do this, Dr. Woon, or? Sure, cool. So we've got a couple of different issues here. With the alarm fatigue, I believe there's already a group on that. So there should be someone taking care of that. I'm not sure who those individuals are. But training and education part, so maybe something to get out to providers or nurses about getting the lactate orders and the fluid orders correct. I don't know if anybody wants to do that.
Well, I think what we like to do is just send you guys back into your groups and take a look at what we've talked about, reflect in your groups, and if you could pick 1 to 2 causal factors for why we're having difficulty meeting the bundle requirements for sepsis, and think of an action item for that. And then we want to identify a champion for each action item. So we'll send you back into your groups to talk about that 1 or 2 causal factors with an action item of something that we can work on and try to change to improve our care of sepsis.
Spend about 3 minutes on that. All right, seems like everyone's got some ideas. All right, who's your appointees? Appointees, raise your hand. All right, we got Rashawn. Who else we got? All right, we got Mark. Somebody being pointed over at...
Is anybody ready with their action items?
All right, Rashawn?
I think regarding the fluid resuscitation in CHF patients, I think that's a pretty common misconception. And we could work on something to educate all residents and doctors that it's okay to give 30 cc's per ml to even patients with low EFs.
I think that's great. I think we might need to take this show on the road around to some of the other residency programs and to the hospitalist. Okay. How would you feel about being a point person, champion on that?
Okay.
All right. Sign them up. It doesn't all, don't worry. It'll be okay. All right. Okay, who else?
We were concerned about the getting the diagnosis criteria for sepsis completed on a patient in a timely fashion. We were wondering about creating a type of card that would follow the patient that could be printed off and put into their chart and given through handoff through the nurses, ensuring that these tests have been done to ensure that a lactate initially was drawn and a follow-up lactate was also drawn, just to allow for better handoff if a patient comes in with sepsis around or near shift change.
Good, excellent.
That's a really interesting idea, Mark. And Mm-hmm. By SBAR, do you mean something on Epic? Okay. I think, yeah. That's a really interesting idea. You know, I've talked with some of the Epic analysts or informaticists about, can we get that in Epic where we actually have a timer and we have a list of things, and so that's an option. But if that's not something we can do in a time-sensitive manner, something on paper may make sense. So, great idea. Can we sign you up for that, and we'll think more about this? Okay, awesome. All right. Who else? Anybody else have an idea? You guys have an idea?
We just have basic education for our nurses, like reminding them to document when they give boluses from the bag, like the time that they documented it. Just giving them some of the basic stuff. Like I guarantee you that they don't know about the CHF and fluid resuscitation, and a lot of them don't know how often we're supposed to be drawing lactates and stuff like that.
Absolutely.
It's just not been as much of a priority as some of the stroke education and other stuff.
Yeah. And which units are you guys representing?
Medical ICU.
Medical ICU. Okay, so that would be amazing to take some of this education back, and I guess Natalie's saying that she can help, so that, because you guys could really help us make sure we're meeting these bundle requirements. Absolutely, that would be awesome. Okay, great. We got that down? All right. Okay, anything else? Okay, we've got about 9 minutes left, and I just want to show you a couple screenshots of the BPA and the order set and how they can help you.
So here's that bane of our existence-ness.
I'll talk from here. So let me ask you first, why do you see this? Why is it popping up? What's triggering it? Do you guys know? Well, what specifically? 2 sears plus 1 organ dysfunction. So if you see this, your patient has 2 sears and 1 organ dysfunction. Epic does not know if they are infected or not, right? And that's why we need a doctor. So when you see this message, your first task is this patient infected or not? If they're infected, then they're meeting severe sepsis or septic shock criteria. So what I would ask you to do when you get this is, if you have a patient who does not have an infection, then you just click on the bottom, patient does not have severe sepsis or septic shock. That will turn this off for 48 to 72 hours before you would ever see this again, okay? So then if your patient does have an infection, there are probably 2 options. 1, you're making a new diagnosis of severe sepsis or septic shock and you need to place some orders. Or 2, you're already treating it. So I would say in both cases, if you could go back, Sean Singh, I would ask you to please click the button that says Open Order Set, which is the top one, just on the white, right there. Click Open Order Set, and if it's not a problem that's on the problem list, please hit Add Problem of severe sepsis. So once you open the order set, we'll go to the next slide. So here's what you get. So if you look at this right-hand side, if you're already treating the patient, then all you need is that top order. So if you've already done blood cultures, lactate, fluid bolus, you've met the bundle requirements, you just need to let Epic know that you've done that. You just need to X out the bottom orders and just keep the top one that says severe sepsis pathway. And if you sign that order for the severe sepsis pathway, you're not going to see this message again for 48 to 72 hours. Makes sense? And then that's going to communicate to nurses, to everyone else this patient is on a sepsis pathway. And it's a double check for you too, because it pops up these orders. So did you do all these things? Did the nurse draw the blood cultures? Did she draw the lactate? Is everything in place to meet the bundle? So that's if you're already treating them. If you're not already treating them, all the orders that you need are here, right? So everything's going to default on the side. But I just wanted to show you, you do have to click on a fluid bolus. And if you see there under IV fluids, you can choose normal saline or LR. And we've just fixed the order set effective like last week that it's going to default to 30 mLs per kilogram. So it's right there, and you can sign that order and you're going to have the right amount of fluids. Now, if you're concerned if the patient is very obese, you can click on the normal saline or the LR and open the order, and you can choose to use the patient's ideal body weight. And if you just document in your note that you use the ideal body weight, it's going to be less fluid in the case of obesity, and you're still going to meet the requirement. But if you choose to use less than the 30 mLs per kilo based on recorded or ideal body weight, we will fall out of the sepsis metric if this chart is selected for abstraction. And then you'll also see the antibiotics are underneath. I'd also like to point out that the lactate order is now a paired lactate. So if you use the order set, you'll automatically have 2 lactate orders, one to be drawn 2 hours later, which will meet the bundle requirements. Yes?
So the one issue with that, if they're outside of the emergency department or the ICU, they don't have, because I've had patients on PICRA that we try to do ISTAT lactates on, and they can't run it up there. So the issue becomes, you order an ISTAT lactate, but they don't have the ability to do it up there, and it's not like they convert it to lactic acid plasma on there. So that may be an issue on the floor since it's not in the ICU or the ED where they have the capabilities.
And ISTAT labs tend to just hang out and don't actually fall off or get acknowledged.
That's a really good point, Steve. Natalie? And I think it's a really good point, Steve. We may need to add something where you can choose from serum or ISTAT lactate. So I really appreciate that feedback.
And the only other issue is with the volume resuscitation, because when they start the actual 30 cc per kilo order, once they start it, it marks it as completed or started. So you don't truly know if that person got, let's say they transitioned from the ED to the floor, if that person got 1 bag in the ED and they still need another bag or 2 upstairs, there's no, and that falls to the handoff issue as well. Because there's some are like, well, I guess they got it, I think, maybe, I don't know.
Eyes and nose are probably should be on, like strict eyes and nose should probably be on this thing, but they're not. So
But even at that point, how many times do you order
it never gets done. So,
Great points. And just the last thing I would say is that documentation is so important. So what matters is documentation that ends up on the discharge summary. So if you start to treat someone and you think you're not sure if it's pneumonia or CHF or what's going on, and you make a decision that they don't have sepsis or they don't have an infection, please document that. Take it off of the problem list and just one line, sepsis ruled out or pneumonia ruled out, that will take care of it. So I audit charts all the time, and there's a lot of confusion about what the patient actually had from the coder's perspective, and that's what ultimately matters in terms of how we're rated for the care that we've delivered. And also, I would say that, you know, we're the clinicians, so if your patient, even if you're getting a BPA and it's firing because their creatinine is 2 and they have an infection, you know if that's chronic kidney disease or chronic liver disease. So ultimately, you make the decision, and you can certainly document, I don't think this is severe sepsis for this reason, and that will be completely adequate. All right, any remaining questions?
heights need to be documented for ideal body weights.
If you hit defer for chart review, the BPA is going to open every time you open the chart. So that was designed to help you if you're just reading about the patient, so you don't have to make a decision. But if you use it as a bypass, it's just going to pop up over and over and over again. All right. Thank you guys so much. Really appreciate everyone coming. And we'll have our next patient safety conference in February, and we'll follow up on some of these issues.